Okay, I am very pleased to introduce Emily Hilderman because she is a long-term colleague, a great friend, a really positive influence in a lot of people's lives. And she is a board-certified adult nurse practitioner. She provides primary care at UW's neighborhood Northgate Clinic. Dr. Hilderman's clinical interests include community-based healthcare, geriatric functional assessment, living well with chronic disease, and preventive medicine. And she's a member of the Washington State Department of Health Vaccine Science Advisory Work Group. So you can see she brings tremendous expertise for us on this topic of vaccines for the older adult. Welcome, Dr. Hilderman.
Thank you, Dr. Cochran. It is an honor to be here. I've joined many of these lectures over the years, and I've always learned so much, usually something that applies directly into my primary care practice or what matters most to my patients. And so I very much appreciate the opportunity to speak with you guys today. I know we have a wide range of participants today, so I tried to just have this as a discussion so that it's something that presents a really hot topic right now. And even as I was getting ready for this, things kept coming in that updated even the state of the science up right until the point I submitted the handout. So it is something that I worked really hard to try to make everything up to date, but that's part of the discussion around vaccines is how do we communicate with our communities and our patients about vaccines when we keep getting updated information even day to day. So as far as disclosures, I do always like to just note, I have no financial benefits that come to me through vaccine programs or other research or incentive measures. I do also like to talk just a little bit about my kind of background and my benefit, kind of the way I look at these conversations. And I invite each of you to also think about how you come to the conversation. So I always approach this as a primary care provider. I work in an urban clinic, but I have a strong background in rural care as well. My family is all in rural Montana, and so I'm very familiar with the challenges that those communities have as family caregivers and as patients working to connect with these healthcare services as well. So I think it's really important for you to know where I come from. And I also would like to ask if anybody would like to throw in the chat just real fast where you come from as far as, are you nurses, physicians, pharmacists, older adults themselves? Who's listening to this? So I really make sure I target to you specifically. And I see it's blinking. We've got several responses there, but Dr. Cochran, I'll have you tell me what those are. Since once I switch out of
social worker, pharmacist, nursing student, a lot of social workers, care manager, RN, nurse, family nurse practitioner.
Great.
Yeah.
All right. So wide range of things. Fantastic. Thank you, everyone.
So LPN, RN, mental health social worker.
Great.
Adult protective service investigator.
Oh, fantastic. Thank you for being here. All right, so really great range of people. Thank you so much for joining today. I think each of us has probably had a conversation today, if not in the last week, about vaccinations. The top topic right now is, of course, the COVID vaccine, but this talk really does look at all vaccines for adults 65 and over. So I tried to really start out more broad so that we really cover more of what's outside of this particular year of 2021, the top topic. So we'll look at what's the recommendations for everyone over 65, as well as what are some of the common and less common adverse reactions that we may see and how to manage those, and then when those need to be reported and to whom. And then talk a little bit more specifically around vaccine hesitancy and how do we have these conversations with our communities and with our patients on a one-on-one basis to really help them have good confidence in our vaccine systems and know that the vaccine they're getting is right for them and their health and what's going to help them protect what's most important for them. So vaccines, many people are familiar with kind of the basic science. Essentially, we're introducing something into the body to trigger the immune system so that the next time it sees that, it's able to have a response that then keeps the disease at a minimum. And so over the years, we've had many, many different ways to do that. Initially, I remember seeing in old movies where they would have someone who was sick and scrape off a little bit of that measles sore and then put it in a cut on a person that wasn't sick. It's the very first idea of vaccines and inoculations where it really is introducing that live virus into a not sick patient with the goal to reduce the effect that that virus will have for them. We don't do that anymore, fortunately, but we do have a wide range of things that we can do to create that same hoped for effect and see that same effect through the research. So the primary types of vaccines are live vaccines, recombinant or inactive vaccines that are kind of a killed vaccine that then is introduced with a weakened response in the body so that when the immune system sees it again, it responds. And then, of course, the two newest types of vaccines, the mRNA and the viral vectors that we've seen with the new COVID vaccines. Those have been under research for a long time, but are obviously much more in the news now and are hopefully going to be able to be applied to other disease processes besides just the COVID virus. All right, so recombinant and conjugate vaccines are ones that take broken down parts of a virus or a deactivated virus and then combine that in a way that the immune system can respond to. So ones that are examples of this are the influenza deactivated, hepatitis B, and the pneumonia polysaccharide vaccine. So in the pneumonia vaccine particularly, they're using polysaccharides, which are sugars, that then the body is trained to be able to recognize in the immune response, to be able to respond to a wide range of bacteria that carry those same polysaccharides. So it's able to give coverage for 23 different types of bacterial infection within the same series of vaccines. Live vaccines are a little bit more what you would expect them to be as far as that weakened version of a live virus. So these examples are the measles, mumps, and rubella, oral typhoid, the influenza, which is the nasal spray influenza. And it's important to note that that one is not recommended for our patient population. It's only for adults up to the age of 50. And then yellow fever is also a live vaccine. Typically, yellow fever is cautiously used, if at all, in older adults. So we'll also talk about that as we get to the discussion of travel vaccines. And all of those are very important to discuss the patient's history and a history of immunosuppression so that you know we're not introducing a potentially live virus to a patient that's not ready for it. The mRNA vaccines have been in the news a lot, so I have a feeling many of you would be able to give me a counter lecture as far as what you've seen in the research and what we've seen on the news in terms of the mRNA and how that has really been huge in terms of the rollout for the Moderna and the Pfizer vaccines. The CDC has some great information on that, that if somebody's looking for something you can share with patients about how these vaccines actually work. This is actually a screenshot of their PDF that you can get printable as a poster. Really good to have that easy conversation with patients about what's the science behind how this vaccine works. The mRNA is designed to enter the body and stimulate the immune system to create the response, but then to be broken down by the cell. So it never actually enters the genetic code or has that next step into long-term example in the body. Viral vectors are the ones that are used for the Johnson & Johnson primarily, and they use a different virus to be able to carry and stimulate the body to be able to recognize, again, the same immune response that we're looking for in terms of the immune body recognizing the protein spikes that are on the COVID virus so that they can then be responded to by the immune system in a way that weakens the virus before it's able to take full effect. All right, so I know case studies always help me to think about what does this look like in a real patient. And so this isn't a specific person, but it's probably 6 or 7 people all rolled into one that have come in recently as far as following up on other things. And then we have a conversation about vaccines. So Mrs. S is a patient who is 70 years old. She has a history of diabetes, COPD, anxiety, and arthritis. And she really is not a fan of coming to the doctor. So she really has to be borderline sick before she's going to come in and see us or even contact the clinic. She doesn't have a fever today, which is important, but she does have a mild cough. She's taking a couple of medications, which you can see there, notably inhaled steroid and then Tylenol twice daily for her arthritis pain. She's not the best reporter, which I'm sure many of us have met this patient where they have a vague memory of, I'm sure I did that at Walgreens, or didn't you give me that vaccine a few years ago? And she doesn't remember when exactly she got most of her vaccines. And so she doesn't get the flu shot every year because she's heard you're not supposed to get it if you don't eat eggs. And she gets an upset stomach when she eats eggs. So, what would you want to know from Mrs. S? If you were going to talk to her about vaccines specifically, are there some things that you need to know? And I'll open this up to the chat for just a moment. So if anybody has something you want to ask Mrs. S, I'll have Dr. Cochran route that back across to me.
As they're thinking, I'll
Yep.
mention that Mary had asked, wasn't smallpox the first vaccine? Jenner inoculating brave folks with cowpox virus to prevent smallpox.
It was, exactly. And that was one of the very first live where we were putting live virus into people to try to combat a different disease. And so it is a great example of that. Thank you, Mary.
So what questions do you have for Mrs. S that you would pose based on the information?
So I'll ask the questions that I would want to know. So particularly, I'd want to know really what happens when she eats eggs. Does she get hives? Does she get some swelling in her mouth? Or does she just get an upset stomach? I'd also want to know if we can track down a little bit more reliably her vaccine record. We do have a number of different ways that we can get that information, either from her pharmacy, if she thinks she did it with her pharmacy, or from her state database. We've got the WACE system, which is where pharmacies, clinics, hospitals all report vaccines that have been administered, so that you can see that across the system. And I see the chat box blinking. Is that somebody with a question for Mrs. S?
I don't have one yet. Why does she not want vaccines? Why does she accept the ones she does?
That is a great question. And that really is the crux of this whole talk, is what is it that helps somebody decide they want to get a vaccine? And why is it that they're afraid of getting a vaccine or that they're hesitant to get one? So that is an excellent open-ended question, whoever asked that.
That was Mary.
Good job, Mary. So those are exactly the kinds of questions that we want to get more information from. As we're thinking about what vaccines we'd recommend, I think let's run through the rest of the vaccines in the series here and keep thinking about Mrs. S, and also keep thinking about today, May 25th. Would your recommendations be different than if we were seeing her on October 25th for these same symptoms? All right, so influenza, the flu shot, is one of the ones that almost everybody knows about. It is very common for patients, nurses, social workers, older adults, everybody in general, to either be 100% behind the flu shot or 100% I'm not getting the flu shot. Last time I got it, I got the flu, and it's not going to happen again. So it really is something that I think we've probably all had those conversations with patients, especially for our older adults. It is incredibly important to talk about the risk of getting influenza and what that can look like for the older adult and the risk that it has for them in terms of severe disease. Unfortunately, 70 to 85% of the flu deaths each year are in older adults. And so really important to talk with them about their underlying health, their risk factors, and what we can do to help them prevent that. It is something, there's a number of different variations available for older adults specifically. It is something that the CDC does not recommend one above the other particularly, because their top priority and what they really stress in all of their information is that the most important thing is to get a flu shot. If the high dose flu is not available, you should get any flu shot that you can get in the book of the CDC. It is something that research has shown the higher dose flus, Fluzone particularly is the one that I've seen the most recent research on, has a higher amount of the antigen that then stimulates a stronger immune response in the older adult, which is basically how each of those high dose flu shots work. And so it is something that we have seen higher rates of protection when adults are able to get the high dose. That said, if they're not able to get the high dose because it's not available, or they have a reason that they're not able to get that higher dose, then getting any flu shot they can get is important, except for the nasal live vaccine, which is not available to them or contraindicated for older adults. The only contraindication besides not getting the wrong vaccine is if somebody has a severe allergy. So in the case of vaccine recommendations, a severe allergy is not just yeah, it makes my stomach a little bit upset, or I get a little bit of hives. It is really a systemic response. So somebody that's had swelling in their mouth or throat, someone that has full body hives, somebody who has needed epinephrine for a reaction. All right. The next vaccine that people commonly hear of and that has had some updates in the recent years is the pneumonia vaccine. There are two different versions of this. Most commonly, easiest to say as Prevnar or Pneumovax are the brand names for those. So the Pneumovax is the PPSV23, the polysaccharide vaccine, and it is indicated for all adults over 65. Previously, we also encouraged the pneumococcal conjugate vaccine, which is the PCV13, for all adults after they had gotten the 23. But after additional research and really looking at the outcomes in terms of pneumonia outbreaks, we found that it really is sufficient for people to have gotten just the 23, so long as they don't have other weak conditions that weaken their immune system. So people that are immunosuppressed or have cerebral spinal problems, or who have cochlear implants for their hearing. So it is something that previously a lot of people had done both doses, but now we've started to move away from that. However, it's always an opportunity for shared decision making. If there is someone who is on that border, if their health is in a way that you're worried about them having a higher risk for pneumonia particularly, it's worth having a discussion to see if we should do the 13 and then the 23, or whether the 23 stands alone. So it's a great example of really knowing your patient, knowing the risk factors, what are their underlying medications, what are their underlying conditions, and what really is the way we can best support them. As somebody who's working with them as a primary care provider, I have an opportunity for that conversation very regularly. But it's also an opportunity for people that are working with older adults, whether that's social workers or somebody who just has somebody they're worried about, to check in and make sure that somebody's been able to keep up to date on their vaccines. Tetanus and pertussis is one that most people are familiar with. Lockjaw particularly is the tetanus illness, and it is something that we always are watching for in terms of keeping people's boosters up. And so we've had very, very, very rare cases of tetanus because we've done such a good job with the immunization series on these. It is something that for tetanus, we recommend boosters every 10 years. And it is sooner if you've had a wound that got dirty. So if you cut yourself in the garden or had a severe burn, those would be reasons that we would want to do a booster sooner. So if you know somebody who gets a cut and they try to brush it off as, oh, I'm fine, that's a great opportunity to make sure they've checked in with medical care to be sure they're up to date on their tetanus. We also
Emily,
have,
could I just
please.
interject? Someone had asked or mentioned a couple of years ago, the hospital where she was working didn't have the high dose. So the nurse gave her a double dose of the regular flu shot. Was that helpful or wasteful of a dose that could have gone to somebody else?
I can't speak to that case specifically because I haven't seen any research looking at that as a recommendation. It is something that we don't necessarily recommend giving 2 doses back to back, but we have sometimes recommended that people get one in the fall and then one in the early winter, depending on their immune strength and their immune response. So I haven't seen any research that would indicate giving a double dose of one flu shot having the same effect as a high dose flu. But that's an interesting that I think research should look into. Great question. Yeah,
Sorry
and thanks
for
for
the
letting me know.
interruption.
No, thank you for letting me know there's questions. I really want to make this talk useful for people. So let me know as you have other questions, and we'll make sure that we give time for questions also at the end. So as far as tetanus, we were just talking a little bit about lockjaw particularly, which there's no good reason for if we can prevent it. Pertussis, unfortunately, we have seen a resurgence of in Washington State and our surrounding western states as well. In California and Montana, I know we've had a number of increasing cases. It is something that we encourage people to get a booster once in adulthood. And so most people are catching up on that. We originally thought that one was going to be enough, usually at 18 or in early adulthood, to be able to continue. But again, as research has come back to us, we're learning that we need to do more boosters for that. So our current recommendations are that everybody should have a dose of pertussis at least once in adulthood. and then they can go back to getting the tetanus boosters every 10 years. I have seen a number of patients where TD by itself is not available, and so they get another Tdap, and there's not a contraindication to that. But as our last question pointed out, the question is that wasting a dose that another person could get? I have not heard of scarcity in terms of the Tdap particularly, and so I would encourage patients, again, the most important piece is to get that vaccine when it's something that they are needing. And so if the only one available is a Tdap when they really need a TD, then that's probably going to be the best course. I saw another chat box flash. I've got it set up so I can see the flashes there. If somebody asks a question, was there something coming through?
No, it was just parenthetical.
Okay. All right. So, and the other thing I always like to highlight on the tetanus, especially for older adults, Medicare particularly doesn't always cover vaccines. So they cover pneumonia, they cover the flu shot, but they do not in every case cover the tetanus vaccine, nor some of the other vaccines that we're going to talk about. So it is important if you're working with a patient to either have them double check or to know what insurance they have so that it is something that's not going to be a surprise when they get a $200 injection bill. It is sometimes covered at a better rate, so less of a copay if they get it done at the pharmacy or at a more of a retail setting versus in a clinic. I don't know the process behind that, but it is something I have seen many times for my patients where it is significantly less expensive in order to get that. There's also a number of programs through public health or the Department of Health to be able to get those vaccines. If somebody can't afford them, we want to make sure that they're getting them and we can track those resources down. So it's always something to ask and make sure that people aren't avoiding a vaccine because they're worried about the cost. Shingles, you'll notice that check insurance coverage there again. It is something that there's a new shingles vaccine that's out. So previously we had the Zostavax, and so many people have gotten that over the last 10 years. And then now in the last 3 years, there is the new Shingrix, which is a 2-step series and is something that has been shown to be much more effective for reducing that risk of the pain associated with the shingles virus. And so the shingles virus, for those of you who don't know, is a rash that can happen in a dermatome, so that patch of skin that's innervated by a nerve itself. And then it is not uncommon for that nerve to remain painful after the virus has passed. And so it can be something that is incredibly painful. And so the virus has been shown to really reduce that. And so when you've finished both of those doses, it has really been shown to knock that risk down by almost 90%, which is really significant. Unfortunately, it is also one that is quite uncomfortable. And so almost 80% of people experience some degree of arm pain at the very least. I have heard from patients that have done all of the series that they thought shingles was bad until they got the COVID vaccine. So now we've got a new normal to refer back to encourage our patients to take some Tylenol and get through that arm pain. It is a inactivated virus. It is a live virus. And so we want to be careful if somebody actually is having an experience of shingles right there, or if they have other allergies to it as well. Again, those severe allergies. But again, this is one that is typically not covered by Medicare in the clinic, but at a better rate in the pharmacy. But there are also lots of people have multiple forms of insurance. So good to know your support options there. All right, the big topic of the day. I think everybody has probably heard a lot about these vaccines. We have the COVID-19, which has three different options available. I think we've all seen in the news where they need to be separated by at least 21 to 28 days, depending on which one you're getting for the mRNA. And then for the Johnson & Johnson, that's just the one dose, which is that vector-based vaccine. It is something that we're learning more every day about what are contraindications or cautions with these vaccines. Just in the last few days, we've had a couple of updates, so we'll talk about that more in just a minute. It is something that is really in the news, and so I think our patients are really talking about this and asking about this. And I try to ask patients during every visit how they're doing in terms of the virus, in terms of the pandemic overall, and then to tie that back into have you been able to get vaccinated. It is something that we're very careful using these in patients that have immune suppression or have a history of clotting disorders, especially with the new information that's coming forward as we're looking at the patterns in response from some rare cases that have been reported in terms of some severe adverse reactions. So we'll keep talking about those in just a moment. A couple that are important but less commonly talked about, the hepatitis series, so hepatitis A and hepatitis B. Hepatitis A is more targeted towards risk. So it's encouraged for patients that would have an increased risk of coming into contact with the hepatitis A virus. So that's anybody who is older than 1. So all of our patients would fall into that, but who have liver disease or have household contacts with hepatitis or who travel. And so it is something that if you've got someone who's getting ready to go on a big vacation, probably not in 2021, but if they are going on a vacation soon, talking with them about are they protected from hepatitis A, which is usually a foodborne or waterborne illness. It is important to get that vaccine series started at least a month before somebody travels. It is something if somebody is seriously ill, you would not want to give that vaccine during their significant illness. But if they have a mild illness, they would be able to do the vaccine today. Hepatitis B is encouraged for all adults because of its increased exposure that patients will have if they have other illnesses or if they work in areas where they could be exposed to bodily fluids. It is something that's encouraged for all adults, and so it is something that was started in 1991 at birth, and so a number of the younger generations have already gotten that series well started. So it is something to discuss with patients as far as have they done that series? Is it something that we need to get caught up? There are blood tests where you can confirm immunity for both hepatitis A and hepatitis B. So you can check the levels of immunity and confirm if somebody needs to do a booster series. Again, this is one that isn't always covered by Medicare, so good to make sure you know where's the best place for your patient to get that to be least expensive. Older adults like to travel. They see as much of the world as anyone. So I think it's really important to talk with them about what their plans are, make sure that they're familiar with where they're going and what the risks may be while they're there. It is something that typhoid is available in terms of being able to protect them. Again, it is important to talk about, is it safe to do with someone who has a weakened immune system? We would not want to do it with someone who's taking antibiotics at the point of taking the vaccine series. So you'd want to make sure you space that. There's 2 different ways we can do the typhoid vaccine. The live version is the one that is more potent and more likely to have a stronger immune protective response. But the inactivated is also very effective, especially if somebody is going to be traveling soon. So it is something that we have 2 different options for that. And then for yellow fever, it is something that is not recommended specifically for older adults. So it's recommended up until age 60, but is something that if older adults are planning to travel to a place that yellow fever is a high risk, they should talk with their provider about where are they going, what are they doing for infection prevention, is it something that the risks of getting the vaccine are outweighing the risks of going where they're going. And so really talking with them about what is that plan. Yellow fever is also one that is very closely tracked by our global health colleagues and is something that needs to be documented in terms of the safety of coming to and from areas that are endemic. And so it is something that sometimes people need to quarantine additionally, depending on where they have traveled. That CDC website there is an outstanding resource if somebody's getting ready to travel. So if you're dreaming about where you want to go next, the CDC is a great place to check. They have really up-to-date tracking of outbreaks, not just of the COVID vaccine, of course they have that also, but of malaria, yellow fever, Japanese encephalitis, all those other things that people should know before they show up on the doorstep and realize that they need to be very, very careful. Tuberculosis, there is a vaccine available for tuberculosis. We don't have it in the United States, and so it's not one you're going to be giving your patients, but it's one that's important to know your patients may be getting. And so it is something that a lot of other countries, especially Southeast Asia, many places in Africa, have done vaccination for tuberculosis with the BCG vaccine. It is something that is a live virus, and so if somebody has gotten that, the skin test that we'll do will actually flag as positive for them. And so it's important that if somebody has done that vaccine, they don't get the TB skin testing. It is something that many of our older adults, if they've moved to the US recently, may have done that. And also a lot of our care teams have done that if there's somebody that moved to the US from somewhere else that has done that vaccine series. So I think it is really important as we're talking with patients about the vaccines that are available to them to also know what are the contraindications and really what's the latest information on what's safe for somebody to do in terms of their vaccines. The CDC Advisory Committee on Immunization Practices is the clearinghouse for that. It is a group of public health and just general health professionals who advise the CDC and the FDA on how we roll these out. They are the monitoring body that gets all the information back in from adverse reactions, looks at the science, and then makes recommendations in terms of who can and can't get different vaccines. And so they have been very busy, as you might imagine, this year. Primary directions that I think are really important for them to know are, again, that severe allergy and what that is really meaning in terms of it's more than just the general hives. It's really severe hives, swelling in the mouth or throat, angioedema, vomiting that can't be controlled, which is that recurrent emesis, and then a need for epinephrine for an allergy. There's lots of precautions, but it's not a contraindication to getting the vaccine if somebody has had moderate to severe illness at the time you're trying to vaccinate, or if they have a history of Guillain-Barré with a prior dose of a vaccine. So Mrs. S, as we're thinking about what we should do for her, as we're looking at all of those options, we think she's probably gotten a pneumonia vaccine. We don't know for sure which one it was. She didn't mention that she's gotten the COVID vaccine. I don't see that she's done a tetanus. Anybody have a vaccine that you'd want to see if she's interested in getting today?
Quiet bunch.
That's okay. So the ones that I would really,
We've got one.
oh, good.
Angioedema with vaccines or just strong reaction to drugs is the question.
So angioedema, you always want to talk to their patients about what their allergy history is and see if there's any correlations, especially, for example, if they had angioedema from eating eggs, we'd want to know that before we gave them a flu vaccine. So I think it's always good to ask as a general open-ended question, but it is something that's specific to the component of the vaccine itself. So knowing what's in that vaccine and talking with patients about that. So the angioedema is something that sometimes people don't always know what it was that triggered it. And so getting as much information as we can so that we can share that decision-making as we get ready to give a vaccine is incredibly important. So shared decision-making is something that you'll hear a lot today as we just keep talking about what's someone's history, what are they worried about, how do we come to a conclusion together.
So Ramon mentioned that he'd like to know maybe a little bit more about the pneumonia.
Okay.
And Mary's said if she's had a form of financial support, she'd go for Shingles depending on how long ago she had her COVID shots. And Sharon mentioned, does she live with someone who is immunocompromised or with unvaccinated children in the household?
Excellent question. So I think the top priority that I've heard from you guys and that I agree with is, has she been able to get her COVID vaccines? Is her household able to get their COVID vaccines? And so I think that is something to get on the list immediately. I'm not sure who it was that mentioned the question about the timing on the COVID vaccines. And that is up until this past week, we had been separating the COVID vaccines from all other vaccines by at least 2 weeks. As of the last week-ish, that is something that the CDC has relaxed. Now, having collected more data and more information, they're saying that we're able to administer vaccines at the same time as the COVID vaccine. It is something that they're recommending using different extremities. So if you're going to give the COVID vaccine plus another vaccine that's likely to cause muscle pain or other symptoms that would be localized, to use one arm for the right, one arm for the left, so you have a better better idea of which vaccine is causing the symptoms. For Mrs. S, I would really encourage, if she hasn't done her COVID vaccine, starting with that. If she hasn't gotten the pneumonia, if we can't find a verification of her pneumonia, I would encourage her to get the pneumonia vaccine. It would be less likely to have systemic response or even a localized response than some of the others. And then I agreed that the Shingrix would be good to get more information on. So that may be a good follow-up plan to say, why don't we let's catch the COVID as top priority, follow that up with her COPD to make sure she's current on her pneumonia vaccine, and then to follow up for the Shingrix if we can figure out what her financial situation is a little bit more. All right, so a couple days later, Mrs. S calls to tell us that after her vaccine, let's say we gave her the COVID shot, she had arm pain with some redness and swelling. And so it is something that's very common for people to have some of that reaction. What is it that we should tell her? Do we reassure her? Do we bring her in immediately? Is it something that we need to report that response to someone? So it is something, just kind of in the nature of time, I'm going to kind of answer those questions myself, because it is something that we see really regularly. And this is a mild reaction, but anybody who's giving vaccines, whether that's a clinic or a pharmacy or a volunteer site that's jumped up, should be ready for those severe reactions and should have things in place to be able to respond, especially if they're giving COVID vaccines, to monitor and respond to an emergency if it happens. I think it's really important to talk with our patients and our communities about how we're ready for these things if they do happen, as part of that reassurance that we know these are rare, but we're ready for it if it does happen. Did I see a flash there of someone with a question?
Yeah, Mary was just mentioning cool compresses and keeping the arm moving.
Perfect. Yep. I can tell that Mary has had a reaction that she's talked to somebody about. So exactly, those cool compresses, massaging the arm, Tylenol or ibuprofen are all excellent for that. So where to report it? This would not necessarily be something that we would need to report in terms of kind of that expected common and low grade response. But this is the website for a severe reaction or something that's unexpected. And so the VAERS, or the Vaccine Adverse Event Reporting System, is something that providers who are administering vaccines would report to. It's also where, if you're someone who sees someone coming in later, so let's say somebody got their COVID vaccine and came in a week later with severe symptoms, the person treating their severe symptoms would be the one to report. And so it is something that this is a good resource to know, whichever end of that you may be seeing patients. And then there is a patient-based side of this, which is the vSafe. And so it's a way that the CDC is tracking patient-reported responses. And so it sends people a text to check in. How are you feeling today? Any fevers, any sore arm, any fatigue? Do you feel significantly worse than you did before the vaccine? And they have a very systematized every day for the first week, and then after that weekly, and then every few months. So it is a great way for patients to both participate in the research that's going forward. We are all basically in a clinical trial, particularly with the COVID vaccines, but it is something that is available for other vaccines as well. So here is those rare but and common ones. And as Mary was saying, absolutely, if there's that localized reaction, it's really first aid based. And so I think a lot of people just naturally treat this, and we don't even hear about it from some patients because they're kind of expecting it, especially with that redness and that tenderness that patients can get. I always try to prep them about that before they've gotten the vaccine, because then they know it's something that we're watching for and that is common and that we expect, so that they can start treating it right away. So if they are having that, taking Tylenol, depending on what their medication combinations are, ibuprofen, and then ice to help cool it down. And then if they're getting worse, especially if that swelling is spreading or becoming more painful, or they start to have other kind of more systematized responses, we'd want to hear from them, absolutely. More severe reactions. Anaphylaxis is one of the big things that patients worry about, that we worry about as medical providers. The CDC has an excellent step-by-step guide on the response to anaphylaxis. This is a great response just in general for anyone who wants to be up to date on first aid to know. But it is the recommendations that are carried forward in terms of vaccine administration sites and what needs to be available in terms of supporting patients that are having a reaction. One of the biggest things is having epinephrine on site, having staff that are ready and prepared to give that, and activating the emergency medical system. I'm not going to walk through all of the steps on this, particularly in relationship to time. I want to make sure we have a lot of time to talk about vaccine hesitancy and concerns people may be having around that. But the CDC and the ACIP have some great and really easy to use resources on this. So I recommend this website highly. Guillain-Barré, I think a lot of people have heard of and heard horror stories about, but may not know some of the underlying causes for. And we're still really learning a lot more about this condition. It's a rare but very serious condition where we think the immune system is triggered into attacking the person's nerve cells. And so it is usually associated with really rapid onset and universal muscle weakness, changes in sensation, so feeling like you're not touching things very well or being able to control your movements well, and then significant body pain. Unfortunately, there is no cure for Guillain-Barré, but treatment and the supportive care that comes with that can really reduce the severity and the duration of symptoms. Many people who have this severe reaction do have ongoing symptoms, and so it is something that's really important to watch for that history. It is something that if somebody's ever had Guillain-Barré from a prior infection, you can get it without it being from an injection. It can be from a different infection. So it is something to really talk with patients about their history. And there are, as we're giving vaccines, there's really those protocols to go through as far as people's history. So making sure if you're not the one giving the vaccine that you know all of those steps have been done. All right. Cerebral venous sinus thrombosis in the news a lot over the last couple of weeks. Serious complications that we've seen after vaccination with the Johnson & Johnson vaccine for COVID typically has been seen within the first 2 weeks after vaccination and almost always in women under 50. It is something that is coinciding with a low platelet count. And so our typical treatment for a thrombosis like this, we're not able to use, which is heparin. And so it is something that as a medical team, we're really, everybody is watching for patients coming in, making sure we know timing on COVID vaccines and having a response for this. It is important, even when these patients are less likely to be in our older adults, but still important to talk with patients about their history and really go through that shared decision-making in terms of which is the right vaccine choice for them when it comes to the COVID vaccine. Just in the last 2 days, I sent Barb the slides, and here we had 2 days later, the myocarditis and pericarditis cases that came out as flagged by the ACIP has been in the news even just in the last 24 hours in terms of inflammation in the heart, the actual tissue of the heart, myocarditis, and then in the pericarditis, which is the tissue surrounding the heart, after the Johnson & Johnson or the Moderna vaccines. It has been seen more often in young men, so again, safer for our older adult population, but we're really learning a lot about this as we go. And so having those resources to be able to talk with your patients about is really important as we keep getting new information, because I can guarantee that older adults are watching the news and they're worried about this, both for themselves and their family members. And so being able to talk with them about what we know, and that this really is a case of our system working how it is supposed to work. The ACIP flagged when we were seeing these cases, and they put out warnings so that healthcare providers are watching it, talking with patients, making sure that we are staying well ahead of this and knowing which populations are safest to use these vaccines in. In terms of symptoms for people to watch for of this reaction, chest pain, especially really sudden stabbing chest pain, is always a symptom to follow up on urgently. There's one thing you take away from this, please remember chest pain, follow up urgently. Also shortness of breath or an irregular heartbeat can be part of that same symptom. It can be something that is triggered by infection in general, but it is something that we're looking at the correlation with cases after people have gotten their mRNA vaccines. So if you are somebody who's talking to someone either in clinic, in the community that's having these symptoms, can be very urgent, especially if they've recently had their vaccine. and the provider, again, who is evaluating those symptoms should be the one who sends them to VAERS. So the American Heart Association just put out a press release on this on the 23rd, which I found very helpful. They did a really nice job breaking down the science of what's happening, both in terms of monitoring the vaccines, and then also it's much longer than this. I didn't bring the full thing forward, but also what to watch for in terms of symptoms. And ultimately their recommendation as the leading association looking at heart health and taking care of patients that have chronic heart conditions, their recommendation is that the benefits of the vaccine outweigh the risks of the side effects as we know it right now. And so it really is something that continuing to talk with patients, continuing to watch closely is the key piece. So before we move to vaccine hesitancy, I think I saw a couple of flashes there. Any questions before we move into the conversation about vaccine hesitancy?
Not at this point.
Great, great. So vaccine hesitancy is kind of a catchphrase, but it really just is, what are the questions that patients have, or what are the things that make them pause before they agree to get a vaccine? It is something that there's a lot of history behind. Unfortunately, our medical systems have a long history of using different races, people of different communities in ways that are not fair or just to those communities. And so a lot of different groups have natural suspicion of being the first one in line to get a vaccine. And so it is something that really having those conversations with patients about their experience, about their personal experience, or what they've heard from their family, their friends, their communities. What is it that they are most worried about? Many people are also worried about the companies that make the vaccines and what their history has been in terms of using people equitably or not in their vaccine trials. And then also religious beliefs, especially around components of the vaccines, whether that be prior fetal tissue or pork byproducts. It is something that our vaccines now do not have active fetal tissue or pork byproducts that I'm aware of. And it actually is something that many religions that you may have kind of prior conceptions of, especially around Jehovah's Witness or some of the other more traditional religions, have moved more towards a pro-vaccine stance. And it is something that looking at the community benefit of vaccines versus allowing the natural course of a pandemic to continue. And so it is something, if somebody has a religious belief, it's one of the main reasons that people will cite as far as not getting a vaccine, asking them more about that and asking if they have a community member in their synagogue or in their church that they would like to go and talk to about what that vaccine might mean for them and for the community. We just finished talking about pericarditis and some really scary side effects and adverse reactions that people can have potentially following a vaccine. And so really getting down to the root for patients of what is it that they've heard, what are they afraid of, and then how do we help weigh those risks and benefits together in shared decision making. So as far as the COVID vaccine, we are making, this is the Department of Health dashboard from last week. So we've made a couple of more points in percentage in terms of our population getting up to speed since, but we're making good progress, particularly in some of our more urban sites. We still have a lot of work to do in our rural communities as far as helping our older adults get connected with vaccines. And so that really goes out to everyone in the community as far as how do we have these conversations to help people get connected and get vaccinated. It is something that a lot of these tools are really being pulled together around the COVID vaccines particularly, but I think they can really be extended to other vaccines as well. If you're having a conversation with somebody about the flu shot or the pneumonia vaccines, is it something that they have, again, every time they get the flu shot, they get the flu, so they're not going to do that. How can we talk with them about what information we know from research? So I always encourage, and the research has shown, to really keep your questions open-ended throughout this. Several of you have had great examples of that, where you ask an open-ended question about, tell me more about your pneumonia vaccine, or about your allergies, or about what you're afraid of for that vaccine. And then having information available to patients in a way that is easily accessible to them. There is an incredible amount of information online Not all of it is high quality, but also, is it something everybody can get to easily in their language? Is it something that's easy to read as far as the print? Is it something, even if it's in their language, that's in a level of writing that they can really easily understand in terms of health literacy? So making sure that you've talked with them about that. And then also, if you're comfortable with it, sharing your experience with the vaccines. Were you able to get your vaccine? How did it go for you? And then making that personal connection of, I got this because it's important to me to protect my family or my community. And I encourage all my patients to do the same. So having some ways that you kind of feel comfortable talking with each of your contacts about that is really important. And then thinking about trauma-informed tools. This is something that was put together by the Washington Department of Health, particularly for patients that are experiencing homelessness. But I think it's a really excellent tool to be able to expand out to other groups as well. And so asking again that open-ended questions about whether or not you've thought about getting your vaccine. And then yes or no. If they say yes, great, let's sign you up for that. But if they don't know, or they're kind of even more so, I don't think so, asking a couple of follow-up questions about what has been their experience, what are they hearing, especially with everything that is in the news, on social media. It is something that really being able to ask those questions and for them to be able to give you an honest answer. If somebody comes in and says, I've heard X, Y, and Z, and you treat them like that's a foolish thought or that they're not wise enough to make their own decision, they're less likely to trust your recommendation. And so really coming into that conversation gently and asking the question and helping come to shared decision making. So if you start that conversation, hopefully it'll be able to continue and move forward within that same visit. But it may be something you have to revisit and kind of have over several different touches. So if somebody is really hesitant and not ready, asking if you can give them some more information to read and then set a follow-up appointment or help them to schedule in the future, and then making a plan. So it is something that you're always, I care about you and I want you to come back and get this when you can, or to actually help them set a date for the vaccine. Many of our clinics don't have the COVID vaccines in clinic because of the nature of how it needs to be stored and how we need to get it to people quickly. And so helping them find a location that they can get it is very important. So that is an excellent tool. It is available online. So you can get it. The website is right there at the bottom. So you can, if you just Google trauma-informed COVID vaccine, you'll get that whole list right there if you don't want to print the whole thing. So thinking about Mrs. S, thinking about everything we've covered today, we are right on the timing that I wanted to open it up for questions, and then I have some more resources at the end. Does anybody have additional questions or thoughts about that trauma-informed discussion? What are some of the questions you'd want to follow up with?
Emily, I'm wondering if you can talk a little bit about vaccine hesitancy related to the fact that some of these older adults are parts of families where there has been vaccine hesitancy about the children getting vaccines and concerns, and do they raise those issues with you about other vaccines?
Yeah, no, I've had lots of older adults come and talk to me on kind of both sides, as far as I really want to get my grandchildren vaccinated for the flu or for HPV or some of the other vaccines that are available for kids, and not knowing really how to start that conversation with their family. I've also heard from a lot of older adults recently in terms of worries about, how is the research really for kids? Do we know that this is going to be safe for them coming out? And I think that really is the delicate conversation to have with our patients in terms of, here's what we know right now. Here's all of the research and the steps that we're doing to try to make sure that that is safe. And here's how we're rolling it out for our younger community members. And so making sure that they've got access to that if they're tech savvy, getting them connected with the CDC website to keep up to date on things. Our public health websites also have really excellent information and information about where to get the vaccine if they're not sure. Up until relatively recently, I was hearing mostly from patients that were having trouble finding the vaccines. or having trouble locating ones that they're able to get in a timely manner. So a lot of it was around more difficulty finding it that I was hearing, but I have had a number of conversations with older adults. Usually they tended towards, I want to get these vaccines, and my adult child doesn't think that they should get them for my grandchild. Has been a very common conversation. I don't have any research numbers on that, but that has been my experience in practice.
Lorraine mentions that she thinks it's getting very difficult to talk to people who feel it's political and not medical. She said she does like some of your language that you bring up.
Thanks, Lorraine. Yeah, I think it's incredibly important. It is. I have patients of all political backgrounds, as you might say, and it really is important to keep the conversation as science-based as you can, as non-judgmental as we can, because on both sides of that, it is very easy to have it become polarized. And that is something that our social media streams have helped in some ways as far as getting information out to people quickly, but it also can become kind of a reinforcing cycle in terms of only hearing one side of a story. And so having lots of different avenues to introduce that information is very important. But I really agree, it's hard to start the conversation. And so really having kind of comfort in yourself of knowing the science behind it and what those recommendations are, so that then if you come back with a political counterpoint, you can say, here's what I've seen in the research, tell me more about what you've read. So that it hopefully continues that conversation instead of getting it all shut down. But it is a very important, and as you're documenting your shared decision making, you know, people are having serious adverse reactions with some of these. They're very rare, but it is important to talk about. And the balance of that is people sometimes put themselves more into that place versus seeing the risk of having the disease itself. And so the risk of having severe COVID versus the risk of having a severe COVID reaction are two very different things.
So Mary mentioned that yesterday in one of her COVID echo groups, a resource was shared, and I think it did go out to all attendees. So I'm going to paste that into the chat box.
Great.
Oops, forgot the Y of the
Mary, you just read my mind, because that is the next series of things I wanted to talk about. So I'm going to go forward so we've got time to cover some of these, and we can keep coming back to questions. This is a little more open now. So I did bring in some of my favorite resources at the end here. The CDC is our clearinghouse for all things related to vaccines. So they keep up-to-date recommendations, restrictions, rates of adverse reactions for all vaccines, in addition to, of course, incredible amounts of information about the COVID vaccine. This is the link to the Advisory Committee on Immunizations. Their website's not quite as shiny as the CDC's main pages because it's very scientifically based. But if you are somebody who really wants to follow along with what are the best practices, what are we seeing as far as these adverse events that are being reported, and to kind of get to the root of the data, they really are the clearinghouse for that. So they are the ones that are really giving us the guidance on how to use these safely, and then they guide the CDC policy. And of course, people trying to find the vaccines, I brought in one of our national sets of resources here, since I know we have people joining us from more than just Washington State. And so this is the National Clearinghouse, but I also highly recommend the Washington Department of Health. All of these resources, wherever you're living, aside from being able to sign up for one on the corner of Pike and Pine, these resources are excellent in terms of the science background, in terms of how things are working, in terms of how we're getting it out to our communities. And so the Department of Health has excellent resources on the COVID vaccine particularly, but also vaccinations in general. COVID has kind of taken over in terms of our focus for infection prevention, but influenza, pneumonia, all those other diseases are also very important for us to stay ahead of. I've seen a couple of flashes there. Are there a couple more questions?
The text is mostly related to this resource that was shared called "Your Friend Doesn't Want the Vaccine, What Do You Say?" And so I'm putting this into the chat
Yep.
box for everyone.
Excellent. Yeah, I did see, I saw, I think the New York Times put that through. I've seen it, a couple of different sources have shared that as far as a conversation starter in terms of how do you kind of respond to some of those questions. Excellent. Thank you for sharing that. And then I also like to make sure people know about their local public health department. So here in Seattle, ours is King County, and they really run a number largely focused on children, but they also have a lot of low-cost vaccination clinics for people that may not have access through other means. And so it is something that are having trouble accessing either the shingles vaccine, the flu vaccine, pneumonia vaccines. They really can help get people up to date. All right, and whoop, my computer's all locked up. Sorry, just like there we go. So you guys already kind of jumped to the end here, which I really appreciate as far as some of those resources to share. Has anybody else found other resources that were particularly helpful for you or that have helped with some shared decision making as you're talking with friends or community members about the vaccines?
Well, they're thinking about that. Cam mentions what are your thoughts on the COVID vaccine for people experiencing post-COVID syndrome?
You know, we are learning so much from COVID. It really is something that we continue to learn week to week, month to month, in terms of some of our treatments that are available. We are seeing some hopeful response back from patients after they've gotten the vaccine series to have an improvement in their post-COVID symptoms. But we also are watching in terms of, do people have a bigger response with the COVID vaccine if they've already had COVID? So it is something that's a really interesting avenue of research that's happening and that I'm hopeful about. All right, any other resources?
Or
The
questions
VA,
or
yeah, please.
experiences.
Or experiences, absolutely. I do know the VA also has an excellent vaccine program. I am less familiar with what is covered versus compared to Medicare, which is what I see in private practice much more regularly. But they do have excellent resources for vaccinations. And so asking their patients, maybe if they're in your clinic and they aren't covered for, say, the shingles vaccine, ask them if they have other avenues of support like the VA. Or if you're working out of the VA, then hopefully we're able to keep all those patients protected as well.
Ramon is wondering what has been the treatment approach for the Johnson & Johnson vaccine-induced thrombocytopenia.
In terms of actually treating the induced thrombocytopenia?
I feel free to chime in, Ramon, to clarify. Yes.
Okay. So it is something that we're watching patients very closely. One of the biggest things is to make sure we're not treating them with heparin or causing a worsening of bleeding risk with that thrombocytopenia. And so one of the biggest pieces is identifying it as early as possible in the process, and then making sure that we're responding accordingly. So it is something that the treatment for that, again, is evolving. So identifying it as early as we can when somebody's having any symptoms and trying to, again, get a good vaccination history.
Is there any research for the COVID vaccine in regards to those with immunosuppression or specifically systemic exertion intolerance disease, formerly known as chronic fatigue syndrome or fibromyalgia? Sorry.
That's okay. I have not seen research published just yet on that. It is something that we're starting to expand out now that we've gotten it. Our initial research is on healthy volunteers and then starts to expand out from there to patients who have more immune suppression. So I have not seen anything published just yet on that. But again, these are new vaccines and we're very hopeful about how the mRNA vaccines particularly can be expanded out to other disease processes. Excellent questions. Very wide range of interest here. I like it. Okay.
Other questions, folks? Experiences?
Anybody have a catchphrase that worked well for you when you were talking with someone about the vaccines, or that if you were hesitant to get a vaccine yourself made you understand a little better? I don't assume that all 60 of us here are 100% comfortable with every vaccine that we've decided to get.
Heather mentions she got it for her son due to the research on antibodies in breast
Mhm.
milk. And Dan said, all I say is get it now while it's free.
Actually, it's even more than free right now. I've seen a number of things where there's pop-ups happening in partnership with community partners. I think that's a great example, Dan, as far as, what is it that gets somebody in the door? And so there's partners with people that provide cheeseburgers, or seen a couple that'll give you a shot in a beer, or all sorts of different things that you can do to both get the COVID vaccine and also get in for something that's hopefully fun. I think it's great to think creatively as we think about the communities that we're working with, and what is it that's really most important to them in terms of, is it how we're protecting that next generation through antibodies with breast milk, or through just protecting them if you know somebody who's more vulnerable in their immediate family, if you can make that personal connection for them, sometimes that really just makes it sink home. It can also be something that having it come from a trusted community member, whether that's a part of someone's church or religious group, or from a person who's active in their community, really saying, I got the vaccine because I'm worried about such and such, and I hope that you will also. Sometimes that really carries through for people. So I know that the Department of Health, the CDC, all of our communities are really working hard to help people get connected with the COVID vaccine, particularly. But also there's a lot of creative things done around the flu vaccine and other vaccines as well. I know a lot of workplaces, long-term care centers work with partners to be able to make it easier to get a vaccine for people. Thinking about having to take a day off work or leave someone you're a caregiver at home for, being able to leave them to go get your vaccine. Can you have it be something where people get it at the same time? That's been one of the challenges a lot of times in rural areas is, you can't leave for a couple hours to go get your vaccine if there's not somebody there helping your kids or helping an older adult that you're a caregiver for. So really thinking creatively about how we can build those supports. And then I don't know if this question came just to me or to the full chat. So Laura says, I'm not in the business of forcing anyone. I just want to provide you with any information you might be looking for about the vaccine. I like that. I actually have told people I've never jumped from behind a wall and gotten somebody with a vaccine. So it's something that people have to make that decision on their own. And so it is something that really stressing, we're not going to force anyone to do it. There's people talking about what fully vaccinated means, particularly in terms of safety, being out in the community and relaxing some of our social distancing. But it is something that I can't remember who pointed out, but the politics of it are a delicate balance. And so really being able to start that conversation in a neutral and open way is very, very important.
So granted, there's been recent guidance, but are you seeing that older adults are keeping up with their other vaccines right at the moment?
So I've seen an increase, at least in terms of having that conversation around, did you get your COVID vaccine? Excellent. And then, oh, look, you're up for your pneumonia vaccine. Why don't we catch that today since you're already up on your COVID vaccine? I think it's really just brought a lot more attention to all the different ways that we can try to keep people as healthy as possible. Really, our big goal with vaccines is to avoid that severe disease, whether it's COVID, whether it's influenza, whether it's pneumonia. And none of these vaccines are 100% guaranteed to prevent the disease, but if we can make it so that you're not going to get a severe case where you end up in the hospital, that is a huge effect for individuals and for our communities. And so it is something that with all of these, really reducing the degree of risk is our top priority. And then extending that to people in their community through the herd immunity is the next step.
So in regards to making recommendations, Lorraine mentioned that she always likes to say nurses always tell you what the best medical practice is, but it's up to you whether you take that advice.
I like that. Excellent. And I think there's a lot of uncertainty right now that people are feeling, and they really have a lot of trusted members in the community, especially if you're a nurse working one-on-one with somebody, you build such important relationships, and being able to relay that trust into something that then we know is incredibly important from a community health standpoint. I think talking about, you may have a sore arm, you may have some of these things, and if it's more than that, make sure you get in touch with us because we're watching for that too. I think part of the challenge as a medical provider is really being all in for vaccines when also we know that some people do have these adverse effects. And so being able to help them come to that decision together, and making sure that it is something that they're comfortable with their decision, and we minimize that risk as much as we can. Excellent questions today.
Glad to see the activity.
Me too. These are, I think these are such important conversations, and I'm hoping that as we all get very comfortable talking about vaccines, that this carries forward into flu season. This is the only year that I haven't evaluated people in clinic for flu. True, I was on Zoom, so I wouldn't be doing it in clinic anyways this year, but it is something that we had a remarkably light flu year, largely because of everything that was done for infection prevention and some increased outreach to people for the flu vaccine last fall. So it is something that I think has been a success as far as this year in terms of reducing flu admissions.
Are you starting to gear up in your practice for boosters at all yet?
So officially, I haven't seen anything yet for a booster, but I do expect that there will be something coming soon as we're gathering more information. The research is in process. So I do expect that there will be boosters that are coming, but not yet officially. As of May 25th, 2021, not yet. I feel like I should give a timestamp on that. Our science is just expanding so fast on this. It really is remarkable. And making sure that we're really getting that reliable information out to patients, and staying up on it ourselves. So really having a good, reliable resource that you go to that is trustworthy and up to date. These slides that I've done are up to date as of today, but give me another week and there's probably going to be some more information that's really important to know. So it is something that really having that at your fingertips is important.
Well, Dr. Hilderman, thank you so much for all of this really invaluable information, and particularly because it's like completely up to date and cutting edge.
I have some updated slides for you, Dr. Cochran. I'll send you one more.
So thanks everyone for participating. We will see you next week for the lecture on opioids, and then we'll see you again next year. So have a good evening, and hang in there.
Thanks everyone. Be well out there.